Good morning, everyone. Thank you all for coming. I know it's a busy day today with school getting back in session and everything else going around the city, but I appreciate you taking your time to come out with this morning. My name is Ryan Boyles. I'm the owner and editor of Health News Illinois. We have a wonderful panel with us today to discuss the latest in the food as medicine movement. So I want to thank our esteemed speakers so much for sharing some of their valuable time with us today. I am thrilled to introduce Sana Sayal, the Senior Director of Programs at the Greater Chicago Food Depository, Julia Bassett, Director of Food as Medicine, Veggie RX at Rush University Medical Center, and Ryan Yarl, the Senior Manager of Community Development at Aetna Better Health of Illinois. Saria Lofton will not be able to be here today. We send her all of our best. Before we get started, I do want to make sure that we thank the generous sponsors of the Health News Illinois event series. These important discussions would not be possible without their support. So a huge thank you this morning to the Illinois Health and Hospital Association, the Illinois Primary Healthcare Association, Novo Nordisk, and the Illinois Association for Behavioral Health. Health News Illinois is an online nonpartisan news service. In addition to hosting events like this, we also publish a daily email newsletter. If you're not a subscriber, I encourage you to sign up for a free trial. You can do so at our website, healthnewsillinois.com, or just talk to me after the event. Happy to help you out. And with that, I'm going to jump right into our discussion. And Sana, unfortunately, you're in the hot seat, so you're going to start things off with you. And I do want to give each of our panelists, a chance to speak on this. And just kind of set the stage for the rest of today's discussion. Sana, just what is the current state of the food as medicine movement? And just kind of in your own words, what do you see as the value of these efforts?
Yeah, well, thanks everyone for being here and thanks for the opportunity to be on this panel. Just to give a little bit of introduction to the Greater Chicago Food Depository, for those who don't know, we are part of the National Network of Feeding America, so we are one of 250 food banks across the country that provide emergency food nationally. Our area, our region is Cook County, so Chicago and the surrounding suburbs, and we partner with over 850 organizations to provide food out in the community and provide benefits, enrollment, and assistance. And so food as medicine is something that has been part of our work for, I would say, decades, but definitely in the past 10 to 12 years. And we've seen a lot of shifts in recent history. I would say there's momentum around food as medicine. There's a lot of growth around the work, a lot of other organizations stepping in that historically have not been in this space. And there's opportunity from a policy standpoint with the 1115 waiver to potentially even get reimbursement for these efforts in a way that we haven't seen before. So I would call out that momentum. I think there are some threats, but we might be getting to it in some of the other questions, so I'll say that.
All right, a little foreshadowing there. Julie, I want to go to you just kind of on that same question. Just what do you see as the state of food as medicine right now? And just kind of what are your thoughts? What are the value of these efforts?
Yeah, so when I think about food as medicine, especially when it comes to Rush University Medical Center, we have community health workers, we have care navigation, we have medically tailored meals, we have produce prescription programs, and that's great, but that's not enough, right? It's such a band-aid approach when it's coming from a hospital system because it's not a sustainable feature for all of our participants. So the 1115 waiver will definitely help to entice the process of food as medicine from a perspective of a hospital, right? But for Rush specifically, we have added this to our institutional strategy. So food as medicine is part of our strategy in terms of looking at the data points, ensuring that we're supporting our patients holistically and thinking about it as continuity of care. And so being able to add that to our community health needs assessment and implementation plan, which is a system-wide report, is really important for us so that we can look at the data and the trends over time.
Absolutely, great. Ryan, I want to go to you on that. Just kind of, what's your perspective on this?
Absolutely. So Aetna Better Health of Illinois, we are the Medicaid plan here in Illinois. We serve over 350,000 members over 102 counties here in Illinois. Food as medicine has been integral to our health plan for years. Piggybacking over some of the things, connecting resources, connecting with organizations like Rush and Veggie RX, and all these great organizations, we feel that food as medicine is moving towards really not just a Band-Aid approach, but just part of your clinical care. And so Aetna really wants to be at the forefront of working with our members, understanding the value of social determinants of health, including food insecurity and food as medicine. try to stay in that space. We recognize that as an insurance company, we kind of are a little bit outside of it, but we feel we can be connectors. And working with different organizations is something that we pride ourselves on, and we'll kind of talk about a little bit more of how we're working in the communities to work with our members and making sure they have access to food in different areas.
Absolutely. You know what, Ryan? Let's jump right into that. We'll go down the line as well. And I want to give each of our panelists a chance to talk on this. But Ryan, for you, for Aetna, just what are some of the steps your organization is taking in this space?
Absolutely. So as I lead the community development efforts in Illinois, we've taken a really strong approach to making sure that our members have access to food and food insecure areas. So as a community development department, we hold outreach events in all counties across Illinois. And a critical portion of each of those outreach events usually revolves around food. So we have food programs where we're bringing fresh produce to our events. It's an opportunity for us to not only connect with our members, but also provide a service to the communities that we serve. And so we're doing programs, nutrition programs. We have value-added benefits that include nutrition education. We offer selected members. We also have some different meal delivery services that you can employ as well. So we are really trying to cover all of our bases to make sure that our members are covered, and because we understand that in order for them to go to the doctor's office, there's so many different things that you have to do before you get to the doctor's office. And food is such a critical component of that. We can't expect our members to make their doctor's appointments if they're concerned about, hey, I don't know where my next meal is coming from, or we don't have any food in the area. So we try to step in that gap and provide all those resources because we know how integral they are to our members' health.
Wonderful, great. Julia, just from you, Rush, just what are some of the things that you're doing in this space?
So I have to piggyback off of Ryan. That's some of the things that we do, but we have different arms of the food as medicine work. So we have what we call one box, one community, where we are doing food distributions in communities that we call our catchment area at Rush. So we have 21 communities, but we look at the communities that really need the support, like Garfield Park, like Austin, like North Lawndale, and we do food distributions in those communities quite often. But we partner with organizations, community-based organizations that are like the boots on the ground, if you will. So we're not just coming in as a Rush, this big anchor institution, and saying, hey, we know what you need, but we're having those conversations with community-based organizations and then being able to deliver on service. So that's one arm of the work. Obviously, our pantry piece is instituted in our hospital system. So we have a pantry, but we have emergency pantries that are both at Rumsey and Rushville Park, and we're looking to scale to Rush Copley. So that's another arm of the work. We also have cooking demonstrations. So we have a mobile kitchen that we have at what we call Sankofa Wellness Village. I don't know if you all have heard of that, but it's located in Garfield Park, and we have cooking demonstrations every Thursday for community members because, as you know, Garfield Park has been exacerbated with the fact of not having a good grocer there, only left in 21, and then Save-A-Lot is also closed in that community as well. So they have one grocery store, if you will, called Dearborn Foods, and that's bulk shopping, so it's not for everybody. So we have that arm of the work, which is our cooking demonstrations, and then obviously we have our emergency food, but we also have a farm, and I think that's also important. We have the ability to grow the things that are culturally relevant for our communities, and then we bring that to our pantry and distribute that to our patient population. So I think that, you can't just have one piece of the work. You can't just do food distributions. You have to have a combination of things to ensure that you are reaching those patients where they are.
Absolutely. Sana, what are some of the things that the Greater Chicago Food Depository is doing in this space?
Yeah, so I referenced like 10 to 12 years ago, we really started getting more into the food medicine space. I would say at that time, it was a lot of us going to clinics and to hospitals to say, how can we work together? And space is always an issue, resources are always an issue at a healthcare institution, and so it often resulted in maybe a pop-up in a parking lot, maybe it was once every 2 months or once a quarter. And we have fully evolved a lot of that work to more so be, how do we support a patient when they're there in the moment and need something, and to have on-site food pantries within clinics and within some hospitals. We also provide home delivery of medically tailored meals to patients that have been identified as eligible for some programming. So also delivering to people's homes directly in addition to when they're there for their appointment. I would say we are dipping our toes in the health payer space of working with payer contracts. It is a challenge as a community-based organization that has never had to think about HIPAA in this way, or SOC 2 or high trust, or all those things, to review those contracts and look at the insurance requirements and really understand how And so when I say dipping our toe, we are in a pilot with Meridian Health Plan as a subcontractor to test out a referral platform that is HIPAA compliant and to provide meals and groceries to people's homes. So more to come, but I think the contracting piece has definitely been an enlightening experience as a CBO.
Absolutely. And Julie, I want to go to you, and again, I kind of want to just kind of talk a little bit and define the food as medicine movement a little bit more before we get into some of the challenges and just kind of from your perspective, how do you see this, addressing health issues, in ways that maybe, traditional medicine doesn't,
Yeah, so that's a great question. So the way our program works, if I could just kind of start there, our referrals are because of a patient who is food insecure and they also have a chronic condition. So we are pre-screening that patient before they even get a referral to our program. So that's first and foremost. So when we're seeing our patients come into the space, they're not only food insecure, but they are layered with 1, 2, sometimes 3 chronic conditions. So we're looking at what our delivery method would be for those patients. So we're looking at the type of food that we're giving them. We're ensuring that it works well with their diet, number 2. We're also making sure that the delivery mechanism is in place as well, because we believe that transportation is one of the biggest barriers for some of our patients coming into the space. So we work with partners who can deliver directly to the door of our patients. And again, it's not a one-time occurrence for food as medicine. We have multiple entry levels to come into the program, but our patients are getting sometimes 3, sometimes 6 months worth of food delivered directly to their door. The other really great thing is if transportation may not necessarily be a barrier for some of our patients, they can come directly to the patient, to the pantry, and then they're receiving 100 pounds of food right when they come. So they're getting the shelf-stable food that is healthy. We look at a swap process for our program. We've delivered that process through Beyond Hunger, who has introduced that to us. So we're looking at the foods that are better for you to eat. So we have those on the shelves, and we encourage our patients to utilize those foods, give them recipes to talk about those foods and how it's catered to their chronic condition or not. And then they're also getting fresh frozen proteins as well, and also dairy items. So they're leaving the pantry again with about 100 pounds of food that first time. And then produce, about 30 to 35 pounds of produce is delivered directly to their door once a month. And then they get that with, they get that for 3 months, and then they can be re-referred to the program by their physician, and then they can get an additional 3 months. So we see a scale of 6 months of being in that program. And we also have community health workers, which is really important. I have community health workers that are in our pantry, but also in both of our emergency departments. And they are looking at resources that can be given to those patients. So we are looking at Greater Chicago Food Depository, and we're looking at their website to drive people to those locations where they can get additional food resources if in fact they can't get it at the pantry or they have run out of more food. And so we're working with our partners. We're not being rushed to be all stand all, but we're working with our partners to ensure that we're looking at additional care for our patients. And so when our patients can get those resources and also have a community health worker who's going to set them up on SNAP if they're eligible is also really important. But also being able to articulate what are certain SNAP issues, in terms of the new regulations that are out for SNAP. So we have community health workers that are also providing that resource to our patients. So we're looking at the patient holistically. And the other really cool thing is that in our EPIC system, we have what we call closed loop partnerships. So we can refer to other organizations that are in our EPIC system and then ensure that we're closing the gap with our patients. So we look at that as a holistic approach for our patients.
Absolutely, great. And Ryan, I want to go to you, just kind of get this insurer perspective on that. Just kind of, where do you see the benefit of these programs for the health of your members?
Absolutely. So we think the benefit of this program is monumental, and this whole initiative around food as medicine is going to be so critical to really the holistic health of members, whether you're in our health plan or not. And so what we do here at Aetna is to make sure that we really serve as that connective tissue. We recognize that we can't do this alone, and that partners are going to be so integral. So working with CBOs as a payer is always going to be an interesting thing, because we are on the other side, making sure that folks are getting their things paid for as they get those services. So we are making sure that we are doing everything that we can to make that process seamless, to make sure that we're working with the proper CBOs and that we're in the correct location. My community development team is making sure that they're in these areas where the need is the most, and making sure that we're holding culturally relevant events. We've had partnerships not only with some of the organizations here today on the this panel, but also Grow Greater Inglewood. We've done several initiatives with them, had chefs come out, prepare nutritious meals, and so all of that reaches kind of culminates into making sure that the entire member is looked after from the very beginning to all the way getting to their appointment. And we recognize that it's so crucial that food as medicine is going to be an integral part of that.
Absolutely. Sonny, yeah, please.
Just one thing I would add, because I think it's underlying everything that both panelists have said, and the question you're asking is like, what is the benefit of these programs? And there's growing research and evidence that shows that there's reduction in ED visits, there's improvements in health outcomes, and so there is a vested interest that healthcare institutions and payers have in investing in food as medicine work. So I just want to call it, I think that goes without saying, because we're at a point now where we're there, but it is important to say that the research continues to grow, and as we talk about MAHA and this federal administration, the emphasis up there now is on demonstrating outcomes is even heavier. So.
Absolutely, and Son, I think you just kind of teed it up and I'll dive right into it. You know, obviously, as we talk about this, there are sweeping changes coming, you know, from the federal government to social service programs, you know, that, you know, serve the same population that, you know, we're talking about really the food and medicine helps a lot. And specifically, as the name of the event says, one of those is changes to the Supplemental Nutrition Assistance Program. And I'm just kind of curious from your perspective, how are these changes affecting this larger food as medicine, you know, initiatives?
I don't know how to make this answer short, so.
No, please, we have an hour, as long as you want to make it.
Well, first, I mean, this is a small enough room. Is everyone familiar what SNAP is and the changes, or is it helpful? Okay.
Yeah.
I see a lot of head nods, so I won't go into sort of the impact of what HR1 said or did to SNAP, but essentially, work requirements, state cost shifting, and reducing the amount of legally present immigrants that may be eligible for the program are some of those big changes. And so for both SNAP and Medicaid, we are seeing the largest cuts and changes in the history of both programs through HR1. And so with SNAP, we are, I think it was in May and June, there was a drop of about 150,000 individuals across the state of Illinois. We've seen about 50,000 of those folks come back on by either demonstrating like, yes, I am truly working, or I am exempt from the work requirements. And so that's great, but there's a lot more work to do, and people will continue to fall off if they cannot prove within 3 months that they have worked 80 hours a month. And so I think, inevitably when we talk about SNAP, there's a few facts that I want to share. The first is, as a food bank, for every meal that we provide, SNAP provides 9 meals. And for every dollar that is spent through SNAP, it generates over $1.50 in local economic activity. And so for Cook County in July of 2024, that was over $280 million in a month that was generated for local retailers, local institutions to be able to have dollars back into our local system. And so that level of an economic multiplier and that level of supporting food access and providing more, just like the ability for people to be able to shop for what they want, is something that I don't think food as medicine is going to be able to ever replace at that scale, at least not anytime soon. And so as individuals are going to lose SNAP benefits, and it's coming for Medicaid too, October is when I think it hits for immigrant populations, and then January the work requirements come into play. That means people will have less dollars to be able to go to all the things that they need to pay for, their health care, their food, their rent, their transportation, all the things will get impacted. So we anticipate we will see more people use our emergency food system. And we know when people lose their health care benefits and trade-off decisions need to be made, that means that health outcomes will be reduced too. And so it is difficult to separate the impact of these changes from the food as medicine work, because I think we're going to see more of a need for support for individuals because of this change.
Absolutely, and Tom, just to stay with you then, just kind of how are you and the Greater Chicago Food Depository preparing, or have already prepared for some of these changes that happen and are coming down the pipeline?
Yeah, well, advocacy has been critical. So I don't know if everyone's heard of the Save Our SNAP Coalition. It's a statewide coalition that we created to advocate for hunger relief solutions. One of the biggest wins from that coalition was the passage of the Fresh Bill, which is essentially allowing all individuals impacted by the work requirements to receive $400 back on their current SNAP card. So if you lost your SNAP benefits, within that month, you would get $400 that is cash, could be used however you need it, not necessarily on groceries, to support whatever you need. And so I think the most that we could do right now is really just advocate for solutions that are going to help individuals at this time. Of course, there is a role for public and private partnerships in terms of ensuring that we have enough food going out in the community, but we have also made the stance that food, we will never charge for food. Food will always be free for our pantries, our neighbors, period, and stop. And so we have had to think about internally, what are the ways that we're going to ensure there is still variety and still the right amount of food across the network of 850 partners. And we can't assume that that's going to be more philanthropy coming in to help us. So yeah, there's some real challenges to think through of how to prepare for that.
Absolutely. Julie, I want to go to you, just kind of, what are some of the things you're seeing in this space as, you know, we see this collision between SNAP changes and the food as medicine efforts?
Yeah, I'm not gonna repeat, Sana said it so eloquently, I think that's perfect. But I think for Rush, this is why we have to reinforce that benefit navigation has to be part of food as medicine. We can't simply give a person information about SNAP and say, hey, you go do what you need to do to get resources, but we have community health workers that are actually benefit specialists, and so we call them kind of our super users, if you will, and so they know how to do the application. They will be very patient with the patient, if you will, and ensure that they are going through the process, because if you answer one question wrong with SNAP, you're automatically denied. So we want to make sure that they have the support, and I think that's really important. And so also making sure that we are helping the patient understand the eligibility requirements, because some people think, oh, it's just a matter of me working 80 hours or volunteering 80 hours, when it's a lot more that kind of goes into that process. So our CHWs are providing that open support. And even when they are no longer eligible for SNAP, ensuring that they can still be part of the food as medicine program regardless of that. And so to Sana's point, our food as medicine program is completely free for our patients. Completely, they don't have to pay for anything. We have braided funding, so that's philanthropically, looking at, the grants that are out there and funding our programs, but also we have a little bit of institutional funding. This is why continuity of care and ensuring that our institutions know that food as medicine is quite important. So when you have those things in place for us specifically at Rush, then we just are able to make it work for our patients. And so they keep us, our CHWs really keep us on our toes when it comes to understanding the policies around food as medicine, or especially SNAP as well.
Definitely. Ryan, just kind of larger, just, in this conversation, just what do you see as some of the bigger challenges facing the food as medicine movement?
I think my colleagues here on the panel really captured it. I think the changes coming with HR 1 are going to acutely affect each and every business line here on this panel. We're very involved in that because that directly affects us from a Medicaid perspective, being a Medicaid plan. So what we're doing to really make sure that our members are making sure they have their paperwork in and we're offering redetermination assistance at all of our events. We also have phone lines and hotlines. We've expanded our call center hours because we know that healthcare is hard. Insurance is very, very hard. Let's just be honest. No one teaches you how to navigate your insurance coming out of school. So making sure that our members are aware of the changes that are coming, the work requirements and all those things, and how they can affect their SNAP benefits. We've created different electronic resources as well as an app called Medicaid 360 for our members on our Medicaid plan. It actually connects your SNAP benefits and your insurance card all in one place. So we're really trying to find ways, because what affects Medicaid is going to affect SNAP. You can't really separate the two, so we have to make sure we're in lockstep with what we're doing, and not only making sure that they have their proper paperwork in from an insurance perspective, but also that they're connected to their SNAP resources as well.
Absolutely. And Julie kind of talked about that, just, obviously the conversation started with SNAP, but there are Medicaid changes coming as well. Just kind of, what new challenges do you see that bringing to, food as medicine efforts?
Yeah, I think part of that is just making sure that they are equipped to understand the process around insurance. Again, we have amazing community health workers who are doing their best to kind of educate our patients that are coming into that space. Because I will say 90% of our patients are Medicaid, Medicare. And so kind of looking at those perspectives and just ensuring that they are, still are in line with receiving their benefits is going to be really important. So we have that education around that. That goes without saying. honestly, is that you have to have the education around that in order to ensure that your patients are getting the best care and that they're not like falling through the cracks. Because we've seen that a number of times with some of our patients who just don't know exactly what to do or how to do what they need to do. So we do have educators that are helping us to support that with our patients.
Absolutely. Sana, I want to go to you, just, before, is there anything else you want to add before we switch gears a little bit? Obviously this is a big issue going on, and to make sure we cover it thoroughly.
Yeah, no, I think I raised the alarm bell.
Great. Well, Sana, I want to go to the other part of our conversation today, from the headline. We're also seeing a kind of a greater changing landscape around how people will get food. We're seeing, greater focus on folks talk about the need for healthier food options. Everything from the Make America Healthy Again Coalition. I was reading online earlier about food influencers. I'm old, I'm out of touch, I didn't know that was a thing. But there's food influencers that talk about that. And I'm just curious if you can talk a little bit about just kind of how this conversation changes, this changing conversation is affecting the work being done in the food as medicine space.
Yeah, it's interesting. Steph just helped host a webinar yesterday around some of this work. And I asked a question in the panel around how this federal administration is sort of emphasizing evaluation metrics, and how is it different than previous administrations in terms of the evaluation metrics we need to be held accountable to for food as medicine efforts. And resoundingly, and this is what I anticipated that the webinar speaker would have said, was that there is a large emphasis on continuing to demonstrate the medical necessity of the food as medicine program, that essentially it is going to the people who quote unquote truly need it, and that it is demonstrating an improvement in health outcomes. And so and the last thing that they said was just ensuring that any perception of fraud, waste, and abuse, this administration is not going to support in any type of way. Which makes sense. It's the rhetoric that we've been hearing, even with SNAP and Medicaid changes that are coming and are here. So I would say what makes it difficult is that, and this was the threat that I was alluding to, is that as a community organization, when we think about health outcomes, there are some real challenges in being able to demonstrate those outcomes, especially if you don't have the data to back it up. I don't have the impact on emergency department visits or hemoglobin A1C or someone's blood pressure, changes, and I would rely on our health partners to be able to share that information. But there are challenges with data sharing, and there are challenges that make some of that demonstration a little bit more difficult. So I would say, while the MAHA work has said we support food as medicine is this bipartisan thing supported on both sides, there is more of an emphasis, I think, on evaluation and proving the impacts than we've seen in recent history. And with the 1115 waiver, it's going to be a real challenge to demonstrate cost neutrality, because the food nutrition support services under the waiver have been delayed to July of 2027, which means we have essentially a year or so to demonstrate impact and cost neutrality. And we've seen in states like North Carolina that waiver and those benefits were taken away. And so I think that's what we're up against. And it's interesting, last thing I'll say, is I've been to 2 conferences on food as medicine in the recent few months, and both had a panel on food as medicine is this bipartisan thing, and they have Republicans and Democrats on stage talking about how we're in full support of food as medicine. But then both conversations resulted in a heated debate amongst the folks on stage because they disagree or didn't see eye to eye on the way that it should be done or the way that food as medicine should be rolled out. And so, yes, it's supported on both sides, but when you get to implementation, that's where you see some of the changes.
Julia, do you have?
Sana said it all. I've been at those conferences before. No, I was at those conferences as well, and it's the same as what Sana said. But what I will say is that it's just really important to ensure that there's equity across the space. I think that that's something that's also missing. We talk about these programs and things of that nature, but we have to ensure that equity is existing with food as medicine programs specifically, and adding that in that dimension is going to be really important for the work. So we've encouraged this standard of care. I kind of wrote something out about that. We've established stronger food standards that encourage healthier choices but those standards only improve health when people can afford the access to food that they are recommending. So I think just kind of like level setting that as well is going to be really important for the food as medicine work.
I wonder, yeah, I want to dive more into that, if that's okay, just kind of talk about how we make sure that this is done in an equitable way,
Yeah.
address the populations that need this.
Yeah, absolutely. I think it's even with the choices that people have to make for food. To Sana's point, it's like you want to provide healthier options. You don't want to just give people food and say you're hungry, let's provide this option. But we, and at Rush specifically for our patients, patient choice is important to us. So we're going to talk about, you have a preference of white rice over brown rice and lentils, right? But we're going to talk about portion control at that point. We're going to talk about all the other things that you can include in your diet that are healthier, for you to eat. So I think that that's also part of our equity and just ensuring that people have the feeling supported at the end of the day, but also their choices considered as well.
Absolutely. Great. Ryan, I want to go to you, and I kind of want to switch gears a little bit and go to something we've kind of touched on a little bit already, is that, public-private partnerships and some of the work being done in that space. And I'm curious if you could talk a little bit about kind of how you see that public-private partnerships and kind of their role in this growing this effort.
Yeah, I think it's integral. If it's gonna succeed, it's gonna have to be not only bipartisan, which in theory is, we hear that it is, but in order for us to really succeed in this area, we're gonna need public and private organizations working together, because we can't do it alone. There's too many steps, there's too many insecurities, there's too many folks out here that need assistance. And so working with partners and CBOs like VeggieRx and the Greater Foods Repository and Grow Greater Inglewood and some of the other CBO partners that we've worked with for such a long time here in Cook County as well as around Illinois is going to be integral in making sure that not only our members but all folks in Illinois who definitely need these services are able to have access to them. So we can, Aetna definitely recognizes this. We don't want to come in as another food pantry or anything like that, but we do recognize that it's a critical part of health outcomes. And so having that ingrained in everything that we do really helps us kind of make those decisions and kind of where we're sponsoring events, where we're adding a little bit of support that we can to make sure that we are meeting folks where they are. And that's really what we've been trying to do as a health plan, is making sure that we are meeting the need of our members and we are where our members are. We're not just telling our members to come to certain sides of town. We're in every side of town. We're in every county. We are making sure that all of our members have the resources that they need, and if we don't have those resources, we're connecting them to those resources. So serving as a conduit is something that Aetna prides itself on, and something that we will continue to do in this kind of uncertain space. We know that 1115 waiver is coming. We've been preparing for it. We'll see what happens with it, and we're excited about the benefits that can happen with it, but we want to make sure that even before the 1115 waiver happens, we want to make sure that we're providing the resources that we have that we need for our members.
Definitely. And Julia, I'm coming to your thoughts. We've kind of touched on the 1115 a couple of times. Can you just talk us a little bit more about kind of what's in that, what the request is, and just maybe some of the optimism and some of the concerns about where that could be going forward?
Well, I mean, it's from a payer perspective. We had a meeting on it yesterday in terms of just understanding what it actually is. And I think what's really important is the reimbursement piece from a Medicaid, Medicare standpoint. That's really important for a lot of our programs, because as I mentioned before, we have this braided funding where we're depending on philanthropic funding to make our programs more sustainable. But just imagine having that reimbursement feature and built into our system and not have to worry about where the next dollar is going to come from to pay for that food for our patients. So that's really exciting for me. I mean, obviously we're in these coalition conversations and advocacy meetings to learn more about what Illinois is going to be and where we stand. We still have a little bit more work to do to get to where we gotta go, right? We've had these heated conversations about that, but I'm really excited about what that could look like from a health institution perspective, because that will save us a lot of money, and we could be able to help way more people in that space, and that would be amazing. But I think I want to really quickly go back to Ryan's point about a payer's perspective. We are working with a private partner, and they're looking at health outcomes for programs. So that's also going to be critical even for Medicaid, Medicare, for this 1115 waiver, is looking at these health outcomes from our patient's perspective and ensuring that food as medicine actually works, right? We can say it works from a standpoint, there's literature out there that talks about, food as medicine, but looking at perspectives of just the produce prescription, also the medically tailored meals pieces of the work, and just seeing how do they encourage health outcomes, because from a payer perspective, they want their patients to be healthier so they can stay out of the emergency department and not look at emergency care as their physician, right? They want them to be healthier, and so I think if we can prove that it works, from our standpoint, that'll be amazing. Hence, I'm putting on my PhD hat right now. I'm going through that process of just kind of looking at health outcomes and making sure that these types of programs work. I know they do, but the data has to say that. If it's not documented, if the data's not there, it doesn't work. So I'm wanting to prove that, and I think my colleagues are wanting to see that too. So.
Absolutely. Sonny, you mentioned dealing with the teen earlier as well. Just kind of what are some of the things that the food depository is working on in that space to kind of prove that these, as Julia said, that this is something that works. This is, we have the outcomes that prove that this is sufficient.
Yeah, I do feel like we have a state leadership that is invested in wanting to ensure we see reimbursement for food as medicine initiatives in our state. Because of HR 1, they've had to make some changes though in the amount of nutrition programs that will be reimbursable. So I think at one point it was like 8 or 9 different nutrition services under the waiver, and that's been cut to, we'll see, but likely 2 or 3 to maybe initiatives like medically tailored meals and groceries and things. So I think for us, we are just ensuring that we stay involved in the conversations. The state does have a work group that's on pause right now, but they really were trying to pull together community-based organizations, healthcare organizations, and payers across the state to have a conversation on how do we roll this out and implement it. And so I think the other thing we've learned though is that we cannot put all our eggs in that one basket because it could be taken away. And so instead we are thinking about what are the right referral pathways to have with healthcare payers and healthcare institutions to receive referrals to us to provide food services, and then how do we have the right billing and payment system on our end to ensure if we want or can be reimbursed, we have that process in place, because we don't necessarily, our finance team, when I talk about this, it's like goes way over there. I'm like, we may need to hire a whole other team, because this could be a whole separate business line for a community organization if they can step into this. So more to come, I guess.
Great. And so I do want to stay with you because we kind of talked about the public-private partnerships, and obviously that's something that the food depository has been, talking earlier about. And whether just talk more about how important that's going to be going forward for these food as medicine initiatives.
Yeah, I think particularly as we're seeing from the federal administration a shrinking social safety net, there is a current need for more support locally, and so we have been out in community and with the Save Our Snack Coalition just getting the word out as much as possible so that people understand what these changes are and how it's impacting us from a local economic standpoint, and for people and their quality of life in their day-to-day. And so philanthropy has played a huge role in supporting it. All of our healthcare partnerships right now outside of one are supported by local philanthropy. Is that sustainable? Is that going to last? I don't think so. And so I think we really are trying to more step into the space of reimbursement so that way we can be supported. And so partnerships with payers is going to be a critical aspect.
So, Julia, I wonder if you want to weigh in all on that public-private partnerships and kind of what those are going to be going forward.
Yeah, I think it's the same with us as well. We kind of are living in that ecosystem right now where we're looking at private, we have a funder that's looking, at those outcomes, but we also have philanthropic, funding for the work, but we also had to apply for like really big grants like GusTim, which fortunately we received in September of last year. But, is that sustainable? It would be nice to get some reimbursement on, some of this work versus just depending on writing a grant every other month to ensure that your work is being funded and that no person gets left behind. So I would love to see that change as well.
So, Ryan, I want to go to you as we kind of talk about these conversations and the importance of food as medicine. Just what do you believe needs to happen to further grow the success of these efforts? Not only ensure that these programs can exist, but they can thrive.
Yeah, I think having having that ecosystem in place is going to be integral. I think one funding source, as my colleagues have really stated over and over again, is not going to cut it for this program, and we need that, how valuable it is to the community. So having payers like Aetna involved is going to be integral, making sure that we are having those mandates from the 1115 waiver. So we're working through those because we want to reimburse. We want to make sure that we're giving back those funds for the overall health of our members. So us really diligently working with the government on the state level, making sure we understand those requirements and what's coming down that pipeline is going to be key in these next few months. I know they are separating it out on what they previously thought they were going to be doing, which happens. But Aetna is going to stay at that forefront. We're going to stay working with our stakeholders and stay working with CBOs and really creating that ecosystem. That connective tissue is going to be key in this initiative moving forward. Any way that we can help is where we plan to step in and really solve some of those issues. And that's kind of how I feel that Aetna, as an insurer and a payer, can really step into this space and provide some real valuable impact and effectuate some change.
Absolutely. Sana, how do you see these programs? How do you see that, the ability to get that future growth, to not only make sure they exist, but these programs will thrive?
Yeah, I think, I hope we get to a point where we're looking at not just health outcomes, but the economic outcomes that may come out of a food as medicine initiative. And there are local leaders in Chicago that talk about this a lot and raise this alarm bell, which I think is important, which is often we think about food as medicine, we're thinking about the community organization that's providing the food and then the healthcare partner that, and how they're supporting the patient. But there's so much that happens before that, or to allow for that to happen, right? Where is that food sourced? What technology platform is being used? Are we supporting locally? Who's delivering that food? There's a whole food system of work that's happening, and we could demonstrate outcomes of food as medicine, not just on health, but on local economic activity too. And so I hope that growth will show the various ways that we can think about evaluation.
So Joy, is there anything like that on that? How do you see these, believe that what needs to happen to ensure that these programs can continue to grow and thrive?
Yeah, I think that, again, as I mentioned before, the ecosystem is really, really important. Having the right funding sources in place, having the right partners at the table, having even community voice. I think that that's also important. They know what they want. I think, again, I don't want to be the big institution that comes in and says, hey, you need healthy food, but it's really about that patient being able to articulate what it is that they need for themselves. Obviously, we need our clinics in place, but we also need, again, sustainable funding to make that happen. And for us, it's adding that layer of that community navigation, that community health worker navigation, and make sure that continuity of care for those patients are happening. So it starts with referral all the way to ensuring that that delivery is happening directly to our patients. So we have to see all of that entire process. And with Sana, what she said in terms of the whole, there's layers of things that happen in the background. Like, we have to make sure that all those pieces are happening so that we can ensure that that patient is getting the best care possible. And so we're looking at local farmers, we're looking at local growers, we're looking at who's delivering that food, what that communication process looks like for our patients. So all of that has to be in place for us to have like a really successful program, number one, but then ensuring that our patients are fully taken care of holistically. I think that's important, and closing that gap so that, if in fact, again, if SNAP is an issue, making sure that they can sustain their health with the food that's provided in their own community. So we look at all of those different things to ensure that we have a program that functions well.
Absolutely. And Ryan, I think we've kind of touched on this a couple times already, but just kind of, as you look ahead, what more do you think policymakers, not only at the federal but the state level, can do to, support these work?
I think the continued momentum that we have and making sure that it keeps growing and that we're pushing legislation is going to be key. I think this is such a vital issue, and I think folks are really starting to understand. Obviously, there's some disagreements at various different levels that we'll hopefully eventually work through, but continuing to push forward. I mean, food as medicine is a rather new concept. Who heard of this 20 years ago? This is such a new concept, so really making sure that not only stakeholders understand and our patients and members, but also our leaders understand the value of these health outcomes and how food as medicine is going to be so integral in the health of the person moving forward, not just working towards going to the doctor, but just from a preventative medicine sort of standpoint, is really understanding how the value that food as medicine is bringing to the table. So capitalizing on momentum, continuing to push
with you because you talk about obviously everyone in here, we're all familiar with food as medicine and the movement, but just kind of curious when those other conversations kind of with the larger population, do you still have to explain what this is and kind of
We have to explain everything.
Yeah.
We have to explain Medicaid benefits, we have to explain food as medicine, we have to explain SNAP. So we know we're not experts on some of these other things, but we try to do to the best of our abilities explain those things. And then we also have great partners. So for your Medicaid redetermination, we partner with Get Covered Illinois and Navigators. We have CHWs across the state of that work and connect folks to resources. We work with different CEOs in this space. So we know that we're experts at nothing, but we try to be generalists at all.
Yeah.
And making sure that we definitely try to inform our folks because we're where they are, and we want to make sure that we have one shot to kind of tell folks everything that we can. And so in that short amount of time, we try to get everything that's applicable to them and pass that information along so they make the best decisions for their health and we get those positive health outcomes.
Sana, kind of as we're talking about, everyone here is aware, but do you have some of that conversation as well? Do you have to explain what this is?
Oh, all the time, even internally sometimes. For sure, yeah. But I do want to stress to the point of like what policy initiatives and things can be put in place. I think advocacy is critical and key, especially right now in this moment. And that's advocacy for SNAP, for Medicaid to keep these programs intact, and it's advocacy for food as medicine initiatives to support locally and have incentives in place for people to essentially be required to have to invest locally to support these programs. But for SNAP, for example, like there is advocacy that was done, it can be done at a statewide and federal level. At the state level, it was all about how do we reduce harm as much as possible for these changes that inevitably are coming here. And at one point, it was 450,000 people in Illinois that could have been subject to losing their SNAP benefits. And through the state's decision to reduce harm and make some changes that would automatically make people exempt, there was about 150,000 people that automatically didn't have to do anything to keep their benefits. And so it's that level of like speaking with our state representatives, speaking locally with our partners to ensure that we are advocating for, if these are gonna inevitably happen, what is the way to do it in a way that can provide the least harm is going to be really important.
Absolutely. And Julia, what kind of building off that, what do you think policy needs to do, state and federal level?
Yeah, I don't think that there's more I need to add about that, but I think it's now then looking at the patient, right? And so at Rush, we want to move beyond asking how much food was distributed. We want to now look at health outcomes and ensure that the patient can manage their health at that point. If we have all of those other things in place, it's making sure that our patients can then be able to eat the foods that they desire, but also in a way that will continue to let them be healthy, but then also be able to procure those foods as well, because I think that's also really difficult in communities like Garfield Park and North Lawndale, Austin. So once we have all those things in place, if a person can do that, then we are looking to make sure that we have created sustainable pathways for people to be healthier.
Fantastic, great. We have about 10 minutes left, so I do want to open up see if there's any questions from the audience. If you have a question, just raise your hand. I'm calling you, and just ask. Let the panelists know who you're directing your question toward. We got a little shy crowd today. Oh yeah, Tanner, please.
Yeah, Tanner Lawson from UI Health, UIC, Government Relations. Just kind of wanted to know, state, federal, local policy. It's a tough time for everybody, but if best worlds of worlds, what would be like one or two policies that would help benefit you the most? I know you talked about 1115 waiver, you talked about a couple other things, but like your Christmas list, what policy would be in place that would, really help move this forward for you?
Ooh, who wants a Christmas present here?
Yeah.
There's a lot.
I know, it's a tough one, but if you
Yeah.
one or two.
Well, those Medicaid determination requirements would be good if something happened along those lines. So
Yeah.
I think that would help our plan benefit a lot because a lot of folks possibly will lose their benefits just from lack of knowledge, lack of notification, not necessarily having the correct information in the system. As we know, we have a data issue just generally across all platforms. And so really making sure that folks have their correct paperwork in with the state, have their correct addresses in, and so that they can get the proper notification, so that they can do the things that they need to do to secure their benefits. That would be my ultimate wish list, for sure, is making sure that we shore up some of those things. There's more information coming down the pipeline. That would be the other wish list is some nice FAQs on kind of what these how these things are going to affect us. I mean, you're saying this is an imaginary world. I would love to know all the things that are happening before January 1st, but you know, we live and we learn, and we'll continue to iterate as we learn more and more information. But I think those by far would be my two wish list items. If I had a magic wand, it could change the world.
Yeah.
Joey, what's on your Christmas list?
Oh my God. You don't just pay for food. You don't just pay. If I could pay for food and not have to worry about writing another grant every other day to ensure that people could be supported and healthier food, right? I want people to be able to have the access that they need so that they don't have to worry about where the next meal is going to come from or debate whether or not I'm going to buy my medication or feed my children. That feels so horrible to be able to talk to people or talk to people who have that issue. If we could have that in place, how much better this, I'm not gonna say this world, but that piece of what we're talking about be so much better.
So it's not what's on your Christmas tree.
Second, Julia. Those are all on my list. I would also just say reversing some other changes that are coming. Even for going back to SNAP, the state will have to pay close to $600 million next year if we don't. And if we don't, then we could lose that program completely in the state. And so that impact, and thinking about the fact that we can provide one meal, SNAP provides 9, and an economic multiplier like that keeps me up at night a little bit. So I think reversing those changes, we know work requirements don't work, and so removing that unmedicated SNAP, I think would be amazing on my wish list.
Anyone else? Oh, yes. Oh, I see you, and then we'll go to you.
I don't have a question, I have a reaction to some of the things we've been talking about. You all talk extensively about evaluating the health outcomes of the program. And as you were talking about the challenges to that, I could not help but think from my perspective, in my work we think about everyone that you all are feeding are the same people we're trying to house, they're the same people we're trying to see in our federal qualified community health centers, they're the same people in pre-K, they are the same individual nested in a family with their own kids. And the outcomes that you seek are the same outcomes that we seek. Everyone that we house can't have the good housing outcomes we want unless they are fed, unless they are managing their health outcomes, unless they are working, right? None of these things can be evaluated fully without those social determinants of health. And so I think my reaction would be to think less about, not that this is helping you with your funders or your payers, it would be ideal in his Christmas list, although to your question I would ask, to what end would you even bother to ask that question, because none of the things that you want you're going to get. What would happen in an ideal world is that all of our partners are thinking about the individual that keeps circling through all of our treatment facilities, community-based programs, and social subsidies, and how are we supporting them fully? Because that is how we get to the outcomes we want. But more importantly, all our data demonstrates some positive outcome towards stability, population health, whatever it is that we need to demonstrate to whoever our payers are, because that is where you're going to get your data. It won't be just by feeding folks. That's like that elephant in the room, and we're all blind and we touch a piece and we say that's the elephant. That's the tail. Housing are the feet. Community health is the snout and the mouth, right? It's all those things together. I know that's challenging, but it is the direction that our state is trying to go to. All of these same entities are invested in the 1115 waiver. We're all trying to be reimbursed by it, right? How long in Illinois have we been struggling to get Medicaid to pay for housing? So perhaps think of it that way, more holistically, through all these participants who are serving the same people. They leave your food pantry, they leave one of your food delivery systems, and they're housed in one of our tenancy units, and they're going to Erie Family Health for their health care. Right? It's the same person. That's my reaction.
No, that's great.
I appreciate that comment. What's unique with our system in Epic is we can make a referral to our psychiatry department or to our housing department, so we can see it we can see continuity of care in our EPIC system to see if they went to that referral, did they get housing, did they get support. So when we look at our outcomes for our patient, we're not just looking at health outcomes, we're looking to see if in fact they got the support based on the referrals that we've given them too. So I think to your point, you're absolutely right, because we have to look at all of those things to ensure that continuity of care has happened in that space for that person. Because
See,
they,
that's how you really the argument. No, feds, we can't prove to you that our food is doing the work, because that same client is also not being housed. So we'll never get to the health outcomes that you and we demonstrate, as long as you're not willing to pay for housing, as long as you keep cutting those HUD subsidies. It's the other part of that argument.
yeah, but you're absolutely right. We just have to be able to, for me, I'm documenting it all. We have it all in our system for our pre and post survey. So we're looking at those screener questions because they're asking about housing, they're asking about transportation, they're asking all those questions. So if we're making those proper connections based on our pre and post survey that we're doing plus EPIC, then we're being able to see continuity of care for some of our patients. We have outcomes for some of our patients that have gone through the program, which is great. And we've looked at all of those things, and a person can say now, we have a couple, at least 45 of our patients, I can say clearly, can say that now I'm housed, I have the transportation I need, I have a job that I now can work, I don't have to worry about being on SNAP. We have some outcomes, they're not the best, right? And it's not for all of our patients. The same mechanism doesn't work for all of our patients, which we know, but at least we are capturing some of that information. So to your point, you're absolutely right. But when we write those up in our grants, we can say, well, we have done our proper process in order to make sure that our patients are being seen in these different spaces, and we've provided that care internally at Rush. And so at least we're doing some of that already. But that's a great point that you made, for sure.
Great. I want to give you.
I appreciate that. Thank you. My questions for the full panel. I'm Ricardo. I represent Prime Care Health, a community health center in FQHC, Northwest Side. We are looking to kick off our nutrition programming at Prime Care, and we're looking to connect with organizations such as yourselves and other local organizations. But I wanted to ask you all, what are some challenges you see with working with community health centers, if there are any, and then how can you be better supported by community health centers in trying to connect with patients and do the work which we're talking about today?
I think for us, space is always physical
Right.
space and a clinic is always an issue because you're competing for so many things within that building. And oftentimes we have a lot of intended folks coming to us to say, we want to provide food to our patients. Can we do it outside of our parking lot? And it's like, we could, but what about weather? What about we would not want dairy or eggs or things out in the heat or frozen protein. So you're only going to get a certain amount of produce. And so there's a limitation in what we can offer when space is an issue. Whereas with something on site, like what Rush has, you are getting the full gamut of all the healthy food options that you should be entitled to. And so I think physical space, and then the time and the reason, who is the staff that is managing the inventory at this on-site pantry, and how are they being supported? I think Cook County Health has actually hired also specific food insecurity folks. That's their dedicated job, is thinking about their on-site pantries, how they're supporting food access for their patients. And so that model has worked, but they had the resources to be able to hire those individuals.
Right.
And so I think there's some real physical and resource constraints.
That's helpful.
We'll take that.
Yeah, I can take a stab at it. I come from an FQ space, working with FQ, so I know acutely how challenged an FQ space could be when you're working with organizations, especially on a food as medicine initiative. I think the operational costs it's integral for an FQ. Most FQs don't have those resources, just flat out. You guys are concentrating on doing the primary care, which you should be doing, and it's great. And but there's other things that you guys should be doing as well, and that includes your food as medicine program and food services benefits. So working with payers like Aetna is going to be key. We work with Prime Care as well as all of our FQs in the state. So making sure that we are providing those resources that we can, making sure that our reimbursements are coming in appropriately, and helping you all in any way we can. We pride ourselves in working with FQs, and FQs are such a vital safety net. Again, to his question, Pat, that's another magic one I'd have. I'd fund FQs as as well. So making sure that we are able to provide those services to you all and coming to you all because you're in the center of the communities. You guys are kind of the hubs from a healthcare perspective, and making sure that you guys are getting all the things that you need to be able to provide those services to our members is key. And I look forward to working with folks like Prime Care and all of Hughes.
So Julia, we're at 10 o'clock. Is
Yeah,
there anything
it's
you wanna add
fine.
quickly? All right. Well, wonderful. Well, we're out of time, so I want to thank everyone for coming out this morning, and I want to thank our panel for giving us their time. They were fantastic today. Thank you so much, everyone. Great. We'll be back here at the end of September. Keep an eye out, healthnewsillinois.com and our newsletter. More information should be coming out here soon. Thank you so much.